So moving on to the next topic, we'd like to call upon Dr. Mahesh, who's the consultant physician and diabetologist at Tumkuru. We welcome you on the stage, doctor. Thank you.
Good evening, everyone. I welcome Dr. Shanmugam A. He is a consultant physician and diabetologist at Chendur Diabetes and Specialty Center and Apollo Hospital, Chennai. The topic is bone health assessment and its implications in diabesity. Warm welcome, sir.
Yeah, good afternoon, friends. At the outset, I'd like to thank Professor LSM and the entire team for the wonderful opportunity given to me. I am going to discuss another 10 to 15 minutes about bone health assessment and its implications in diabesity. I don't have any conflict for this talk. So, we all know that fracture risk is quite high in type 2 diabetes. Almost in type 1 diabetes, 4 to 6% fracture risk is double, almost increased. In type 2, 1.7% risk is high. And those people are taking thiazolidinediones, the fracture risk is increased by more than 40%. So we all know these facts. Before going to my talk per se, some basics about bone metabolism. So if you understand bone metabolism, we can understand about how this metabolism dearranged in type 1 diabetes and type 2 diabetes, how to have a clinical practice to prevent this altered bone metabolism is most important. We all know that there is something two cells called osteoblast and osteoclast. Blast cells are bone formation cells. Clast are bone resorption cells. Normally, bone is remodeling every day, and it is testing bone into activation, bone resorption, reversal, formation, and termination. It happens each and every bone, and throughout your lifespan, it is happening. And this is happening because of two pathways. One pathway is bone formation pathway, another is bone resorption pathway. Bone formation pathway is WNT and sclerostin pathway. The bone resorption pathway is Rankel OPG pathway. These are the two pathways we should know whenever we are discussing about bone metabolism. Let's see one or two slides about these basic pathways. This is Rankel pathway or receptor activated nuclear factor kappa pathways, and there is a ligand. We have discussed that already. We have discussed something called osteoclast and osteoblast. So osteoblast produces Rankel, which is a ligand, and osteocytes, which are bone formed cells, produces OPG. This Rankel, if you bind with the rank receptors which is available in the macrophage, which converted into osteoclast, which will activate the osteoclast, the bone dissection will happen, bone resorption will happen. So whenever this Rankel pathway is activated, it induces osteoclast activity, the bone resorption will happen. There is something called OPG. This OPG is also produced by osteocyte. This OPG will block the Rankel so that the osteoclast activity will not happen. So there is a two systems involved here. Rankel will activate bone resorption. OPG will stop the bone resorption. This is about osteoclastic pathway. And another pathway is WNT and sclerostin pathway. This WNT will activate bones, will create bone. It forms the bone formation should be there whenever WNT pathway is activated. The sclerostin will be the inhibitor of WNT. So whenever sclerostin goes up, it will blocks WNT, and DKK also another inhibitor of WNT, which will reduces the bone formation. Why this is important? This is a nutshell about the bone cycle. There are Rankel pathway which will induces bone resorption, and OPG will inhibit bone resorption, and WNT pathway will induces bone formation, and sclerostin and DKK will inhibit bone formation. Why this is important? In type 1 diabetes, what will happen? The WNT pathway is completely blocked. So there won't be any new bone formation happening in type 1, in uncontrolled type 1. The WNT has been activated by insulin. Whenever there is no insulin, the WNT is not activated, so bone formation will not be that much active. And also the Rankel pathway is inhibited by insulin. Whenever there is no insulin, the Rankel pathway is activated. So in turn, the bone formation is not happening, but bone resorption is activated in type 1. So the people will have osteoporosis, bone marrow density, BMD will be quite low in type 1 diabetes, and fracture risk also quite high in type 1 diabetes. What happened in type 2 diabetes? Type 2 diabetes, we all know that there is a state of hyperinsulinemia. Because of hyperinsulinemia, high amount of insulin will activate WNT. So bone formation will be increased, but at the same time, it also increases sclerostin. So wherever sclerostin is inhibited, the WNT is blocked. So even though the bone formation is there, but is very slow, very minimal bone formation is there with type 2 diabetes. The Rankel pathway has also been inhibited here, so there won't be any osteoclast activity. So here, nutshell, the bone turnover, usually the bone formed bone has to resorb. This bone turnover is quite low in type 2 diabetes because of hyperinsulinemia and advanced glycation end products which addresses the collagen. So basically type 1 diabetes, whenever there is no insulin, bone is eaten away. In type 2 diabetes, because of hyperinsulinemia and advanced glycation end products, bone is not renewed not renewed properly, so that bone is quite weak. It is not formed regularly. This is what the basic difference in between these two. The same thing I've discussed here. Type 1 is a low formation and high resorption, so that patient will have osteoporosis. In type 2, it is low turnover. The bone strength is quite low because of increased sclerostin and advanced glycation end products. The bone is become fragile. So other hormones also have an impact. Estrogen will increase inhibits osteoclast. It promotes osteoblasts. That is why postmenopausal women have osteoporosis. And parathormone, intermittent parathormone will increases bone formation. But continuous, like any hyperparathyroid tumors or hyperparathyroidism, the bone resorption will happen. That is why the treatment will be intermittent parathormone, but not with the hyperparathyroidism will induces resorption. And same thing, cortisol also increases bone resorption. So type 2 and type 1, the basic difference is bone is not formed, bone is much destroyed in type 1. In type 2, bone is formed, but not in the adequate amount, less bone is formed. The same time, destruction is not happening here. Low turnover is happening in type 2. This is what the basic difference in between type 1 and type 2 in bone metabolism. This is what the same thing. So type 1 is not, bone is not formed. The type 2 is, even though it formed because of low turnover, it is not a high quality bone. The risk of fracture is quite high with type 2 diabetes. So having said that, major defects in type 2 diabetes will be cortical deterioration, trabecular structure changes, and low bone turnover. So because of cortical deterioration, the bone marrow density test will be either low or slightly increased, even though bone is fragile. So bone quality pathway, because of Ag accumulation, collagen, cross-linking, reduced toughness, all these things will have impact on the bone. But apart from that, because of peripheral neuropathy, retinopathy, vision impaired, sarcopenia, muscle weakness, because of hypoglycemia, and the frequent falls, which also further aggravates the fracture risk in type 2 diabetes mellitus. So how do we assess this bone abnormalities in type 2? DEXA scan, we all know that is a gold standard. With the T-score, we assess that. Whenever T-score is less than 2.5, less than minus 2.5, we say that it signifies osteoporosis. Less than minus 0.10 indicates osteopenia. The pitfall here in type 2 diabetes is because cortex is slightly thicker, the low bone turnover, BMD may be normal or elevated. So if you calculate FRAX score, it may be equally normal, but the bone is quite fragile. This is what the paradox happening in type 2 diabetes. So we cannot go only by BMD. So if it is BMD is normal, we can't say that your bone is normal. But because of hyperglycemia, obesity, hyperinsulinemia, vascular compromise, AG accumulation, and low bone turnover, BMD may be normal or increased in type 2 diabetes mellitus. Then what else will help us? Another strategy will be trabecular bone score or TPS. It is also a non-invasive test derived from DEXA images. But this test, TPS, offers information about microarchitecture of the bone, particularly the trabecular bone, which is impaired in type 2 diabetes mellitus. So this TPS score will help us particularly in type 2 diabetes, whether the bone is risk of fracture or not. And another method will be vertebral fracture assessment. This also happens very early in type 2 diabetes mellitus. This is also a low radiation method to detect unrecognized fracture, with some microfractures can be assessed here with vertebral fracture assessment. This also helps in type 2 diabetes mellitus. And another high-end technology will be high-resolution peripheral quantitative tomography, which will be three-dimensional assessment of volumetric bone marrow density and bone geometry and microstructure. But this test will tell us about exactly how the bone is, cortical bone or cortical porosity, trabecular data, all these things will give us. But only thing is quite costly one. It is only the research methodology as of now, which is not practiced in many places. And this is a common tool we do use, FRAX scores, fracture risk assessment tool. But unfortunately, whatever the data they do use, type 2 diabetes mellitus is not a inclusion criteria included as a variable in FRAX assessment. The fundamental limitation of the FRAX score in type 2 diabetes, diabetes is not included in the input variable. So we cannot take it as a valuable tool for type 2 diabetes mellitus. Then how to go about this? Another 4 strategy has been added here. Rheumatoid arthritis surrogate markers or TPS, trabecular bone score or T-score can be reduced another 0.5%, or age increment, add 10 years. By adding that, it somewhat mimics type 2 diabetes mellitus. But another strategy is FRAX Plus. What they do, they add diabetes duration. But it is not as validated by international guidelines, ED, all these things. But this is even still in debate. Where can we use FRAX Plus for type 2 diabetes with bone marrow, fracture density? So what about bone turnover markers? We all know that there are 2 bone turnover markers, CTX, which is a resorption marker, and PNP, which will be formation marker. But we have discussed that already in type 2 diabetes, the bone turnover will be quite low. So these markers also will not be much useful in assessing the bone health in type 2 diabetes mellitus. So advantage, each test, bone marrow density, will not be much useful because bone marrow density will be quite normal or elevated in type 2 diabetes. Trabecular bone score, but quite useful, but it is very limited availability. Vertebral fracture assessment also quite useful, but it is also limited availability. And CT, HR, PQ, CT, expensive test only for the research methodology. FRAX we cannot use since diabetes is not a part of it. And bone turnover markers, which is also not much useful in type 2 diabetes mellitus. So the emerging biomarkers will be triglyceride glycemic index and irisin, which is a myokinase marker, and asparagine, which is also a glycogenic hormone, which is also the emerging one, and TXNIP, which is a protein, also be marker of oxidative stress, also be used here. So what about our international recommendations? ADA recommends that all type 2 diabetic patients aged more than 65 has to be assessed with bone health. And if young patient is younger or more than 50 with risk factors like duration of diabetes more than 10 years, frequent hypoglycemia, HbA1c more than 8, frequent falls, if there is associated microvascular complications, these group of patients also be assessed with bone health. Whenever it is normal, reassessed after 2 to 3 years. So ADA will suggest a T-score adjustment mandate from 2024, but not exactly how much we have to adjust. It is not well documented. And ESD also suggests that holistic bone health assessment is needed, and RSSD also endorses that. And what about medications? How to prevent this bone health? How to take care of our bone health in type 2 diabetes mellitus? Obviously, good glycemic control, with the help of insulin, definitely will have a better health of bone and nutrition. Obviously, the more protein intake and physical exercise, resistance exercise will build bone and muscle to our patients, and smoking cessation and limiting alcohol will also. And what about anti-diabetic drug? Insulin will have formation will be better with the insulin. But insulin, as we discussed before, insulin increases VNT pathways. Insulin reduces Rankel system, which is a bone resorption methodology. Insulin also reduces sclerostin, so that bone formation will be good with the insulin. But problem with the insulin is that whenever patient have a hypoglycemia, fall will increase the risk of fracture. So we have to be careful such a way that such insulin has to be titrated so that patient will not have hypoglycemia. Metformin can induce AMP kinase activation, so that it induces bone formation, and it also metformin also increases WNT pathway, and thereby metformin have a good impact on the bone formation. GLP-1 receptor agonist also have a better pathway in terms of it inhibits osteoclastic activity by reducing the Rankel system, and it also promotes osteoblast formation. But obviously, it is somewhat neutral or mildly beneficial in terms of bone health. DPP-4 inhibitors, it is almost neutral. It won't worsen, or it won't be beneficial in terms of bone health. And obviously, thiazolidinones, we know that thiazolidinones will activate PPR gamma, so mesenchymal cells will create a form into fat cells instead of bone forming cells, and it also worsens the WNT cathepsin pathway. Bone formation will be reduced with thiazolidinones, and Rankel expression will be quite high with thiazolidinones. We all know that thiazolidinones will increase the risk of fracture in type 2 diabetic patients almost more than 40%. SGLT inhibitors, there is one data showing that Canvas trial showed the increased risk of fractures, which canagliflozin, which is a strongest phosphate-uric drug, which pushes phosphate into the urine because of co-transport along with sodium and glucose. Because of phosphate is going out, it slightly induces secondary hyperparathyroidism. We know that hyperparathyroidism induces bone resorption. The same way, calciuria also have an impact on the hyperparathyroidism, secondary hyperparathyroidism. It also induces bone resorption. But this phosphate and calcium excretion has been well documented only with canagliflozin, not with the DAPA and EMPA, what we use currently. So as I say, individualized, we can say that Cana is a potent SGLT inhibitor. We all know that. So because of its potency, it has more impact on the bone, not like EMPA and DAPA. So drug effects, bone protective drugs will be insulin and metformin. Neutral drugs will be DPP-4 inhibitors and GLP-1 receptor agonists or incretin pathways. Harmful drug will be TCDs and slightly SGLT inhibitors, particularly canagliflozin. So this is what, putting all together, so this is about the mechanism of bone health. So bone health, we have to take care of bone formation and bone resorption. And hormones also have an impact, insulin, estrogen, and parathyroid. Vitamin D. Vitamin D is a quite important one. In type 2 diabetes, we all know that vitamin D is quite low. So kindly make sure that all our type 2 diabetic vitamin D is quite normal. And it also induces diabetes. Type 1 diabetes will be bone resorptive disease. Type 2 is a low bone turnover disease, and we should make sure that the drugs, whatever we do use, will not have an impact on the bone health. So emerging therapies targets will be monoclonal antibodies has been tried here, Romosozumab, which is a marker which is inhibiting the sclerostin so that bone formation will be good. And we all know that sclerostin will be quite high in type 2 diabetes, which will be inhibited by Romosozumab. So it will be quite useful. And Denosumab, which is also quite useful for post-menopausal osteoporotic women, which inhibit Rankel pathway so that bone resorption will be reduced. And some strategy has been tried with AG, advanced glycation products reduction. So the key takeaways from the bone health in type 2 diabetes and type 1 diabetes, we should keep in that low formation, high resorption, so that BMD will be low. So we can straight away go with the BMD, particularly whenever sugars are not well controlled. In type 2 diabetes, low bone turnover and poor quality. So even though the people will have a normal BMD, it is a fragile bone. TCDs, we have to be very careful whenever we are putting the patient with the TCDs, particularly post-menopausal women, those who have high risk of fractures, quite careful about that. And always treat patients with better bone health molecules and always do consider whenever we are treating type 2 diabetes mellitus. Thank you for patient listening.
Thank you, sir. Thank you very much, Dr. Shanmugam. Any questions from the audience?
Dr. Shanmugam, excellent presentation. I am a very good user of bisphosphonates. Majority of my patients, I initiate the patient. But I have not come across atrial fibrillation, which was reported in some of the journals. Have you ever come across atrial fibrillation following the use of bisphosphonates? And how long in your practice you have been using this?
So I have not much user of bisphosphonates, sir. I've used more of denosumab for our type 2 diabetic patients who are having osteoporosis.
But definitely when it is indicated, but
Yeah.
in the absence of...
I have not used much about bisphosphonates, so I don't have any experience
monthly
about
once or once in a year,
I have not-
injectable
this is-
formulation.
So I comfortable prefer denosumab because it is once in 6 months. So whenever patient comes for review, I ask them just one IM injection. Patients are quite comfortable. Only thing is cost is quite high. That is the only concern. Otherwise, I do prefer, that is why I'm not having much experience about this possibility.
Because
You can-
zoledronic acid we give once in a year.
Yeah. You can tell us.
Any other questions? Thank you, sir. Thank you very much, sir.
Thank you, doctors. Thank you to the speaker and chairperson. We request you to move to the selfie area, which is right outside the hall.